And it is my great pleasure to welcome everyone to today's webinar, Combined Hormonal Contraceptives and Migraine. My name is Jessica Monmany, and I am the Senior Education Associate at ARHP. I will be moderating today's webinar. Again, I would like to share how you can receive continuing education credits for this webinar. In order to receive credits, you must take the pre- and post-test. If you have not yet taken the pre-test, please click the link provided in the reminder email or via the webinar's chat box. You're also welcome to use the chat and question box to ask questions throughout the webinar, which our presenters will answer at the end. About an hour after the conclusion of the webinar, you will receive an email from Caitlin Borsowitz, ARHP's Communication and Education Associate, with a link to the post-test survey. Your continuing education certificate will be generated upon completion of this survey. In 4 weeks, you will receive another email with a link to a follow-up evaluation. We ask that you complete this evaluation to let us know how you have incorporated what you've learned during this webinar into your work. Completing the pre- and post-test, as well as this follow-up evaluation, helps ARHP ensure we continue to meet your educational needs and interests. Thank you in advance for your time and feedback. At this time, I would like to introduce Dr. Pelin Batur and Dr. Ann Calhoun, today's presenters. Dr. Batur did both her internal medicine residency and women's health fellowship at the Cleveland Clinic, where she has been practicing since 1998. She is the education director for the Primary Care Women's Health Program. She sees patients as both a primary medical provider and as a women's health consultant addressing hormonal, cardiovascular, contraceptive, and bone health concerns. Dr. Calhoun is partner and founder of the Carolina Headache Institute in Durham, North Carolina, and is professor of psychiatry and anesthesiology at the University of North Carolina and former senior faculty in neurology. She holds subspecialty certification in headache medicine through the United Council for Neurologic Subspecialties and is a fellow of the American Headache Society. Drs. Batur and Calhoun's full bios are available on ARHP's migraine webinar web pages. We are thrilled to have them with us today, and I will hand it over to them. Dr. Batur, you have the floor.
Thank you. Well, we did want to say thank you to Amgen, who provided support to ARHP so that we can have these webinars. Though we're not discussing any Amgen products today, we are thankful that we get an opportunity to talk about the importance of migraines in women. And there's a little bit of a lag sometimes with the slides, so you'll have to excuse us. Some disclosures. My life is pretty simple. I have nothing to disclose. Dr. Calhoun is a thought leader in the headache world, so as such, she's got research disclosures, and she does do some consulting and speaking for a variety of companies. Importantly, we will be discussing some off-label uses that you should be aware of because no combined hormonal contraceptive or estrogen is approved for the prevention of migraine. Also, for clarity, we sometimes use brand names when discussing combined hormonal contraceptives because there's so many of them that share the same active ingredients. However, they can have a huge impact on your patient's migraine just because of how they're put together, meaning their architecture and their doses. However, we have no individual conflicts of interest related to any contraceptive product. Sorry, there's quite a bit of lag with the slides. So a little bit of neurology for us non-neurologists here. Just remembering how common migraine is. So the incidence of migraine is relatively low when data is pulled from the general population. It's about 13% that are migraineurs, although in reproductive women it's more about a quarter, 25%. However, for patients who seek medical care, the patients in your waiting room, they are much more likely to have symptoms of migraine, more in line with 29% being migraineurs. And in fact, if you look at patients who complain of headache to their primary care doctor, after a thorough history, about over 90% of those, about 94%, end up being migraineurs. In terms of gender issues, the prevalence changes with the onset of age. Each time migraine becomes markedly more prevalent in females than males, and in females, up to 70% report a menstrual association, and this is where reproductive providers can really help these women. We think of migraine as an orphan disease that gets kind of lost in the middle with the various specialties. Many in primary care don't have enough time to address the headaches in full. It really needs its own dedicated visit. And sometimes some primary care doctors don't have the adequate training either. So this is where tension headaches or sinus headaches end up in the chart and stay in the chart, and the hormonal connections of menstrual-related migraine aren't made. As far as gynecology, many providers don't feel comfortable with the diagnosis or treatment of headache, but up to half of reproductive age women are seeing their GYN for their primary care needs. In contrast with neurologists, they don't feel comfortable with the use of hormones, so migraineurs end up stuck in the middle. In fact, some neurologists might not even feel comfortable with headache diagnosis and treatment. This is a survey of U.S. residency program directors and chief residents, and it showed that 21 to 26% require, only 21 to 26% require headache training. Of those that do, most of them were just for 2 to 4 weeks or less than 2 weeks. So of those graduating, 20 to 25% reported that they felt they needed more training. So how do we diagnose migraine? So you need at least 5 attacks that fit into these following characteristics. The headaches should last 4 to 72 hours, and it should have at least 2 of the following characteristics. It should be unilateral, pulsating in quality, although a good chunk of the migraines are bilateral or steady. Moderate to severe pain, or either aggravated for physical activity, or a patient wants to, has a preference to avoid physical activity during the headache. During the headache, also, at least one of the following associated factors should be present. Nausea or vomiting, although a small percentage of patients do actually vomit, and light or noise sensitivity. Also, if a headache is not better accounted for by another headache diagnosis. In the case of aura, we're looking for at least 2 attacks that fulfill the following criteria. So these aura symptoms should be fully reversible, and the patient should have at least one of this list. So the visuals would be the bright line shapes and objects, the more common. Sensory would be burning, pain, paresthesia. Speech or language, anywhere from mild word-finding difficulty to full dysphagia. Motor, the hemiplegic migraines, these are more rare but have a stronger genetic influence. And then with the brainstem migraines, of course, we need to rule out TIAs with all of these, but we're looking for vertigo, dysarthria, where their language skills are intact, but their motor skills to create the words, there's a problem in that area. Tinnitus, diplopia, ataxia, or the retinal migraines, which are the ocular migraines, monocular loss of vision. So any one of those, and then you should have at least 2 of the following 4 characteristics. So one aura symptom that gradually starts at least over 5 minutes, and or it could be or 2 of these that occur in succession. So each individual aura should last anywhere from 5 minutes to 60 minutes. So it can't be a 30-second event is not an aura. And at least one aura symptom is unilateral, and the aura is accompanied or followed within 60 minutes by a headache. And again, not better accounted by another ICHD-3 diagnosis. The slow spreading of positive symptoms, such as tingling, followed by negative symptoms, such as numbness, is characteristic of an aura as opposed to an ischemic event. But with some of these, especially the motor, the speech, you usually do want to do an evaluation to rule out TIA. All right, next slide. Sorry, a little bit of a lag here. So the next slide is should be, if it'll go, should be talking about its effect, referred pain. I'm just going to keep going. I have, so we are experiencing difficulties with the audio conference. I have printout of the slide. So in terms of referred pain, the next slide has a skull that shows the distribution of where the migraine pain can occur. So the one popular theory of migraine that is caused by dilatation or constriction of blood vessels is not valid. So migraine is caused by a phenomenon of cortical spreading depression, which is a wave of neuronal and glial depolarization that spreads across the cortex. And this depression is hypothesized to cause the aura and activates the trigeminal nerve afferent. So we have the ophthalmic branch, the mandibular branch, and then we have the maxillary branch. And I'm hoping that the slide's still on progress moving forward, so hopefully the ARHP folks will help with that. But it's because there can be referred pain to the maxillary branch, that's how you can get diagnosed as a sinus headache. And then the next slide will show a picture of the back of the head, the skull, and it just talks about referred pain to the neck. 75% of migraine patients actually experience neck pain associated with their migraines. And in fact, they're more likely to have neck pain than vomiting. So that's why a lot of times these patients get diagnosed as having tension headache. So if you see sinus headache or tension headache in the chart, it's good to take another look and make sure that you're not indeed missing a migraine. Says network connection has been reestablished, but my slides still aren't moving. So I'm going to keep going. In terms of estrogen and how it affects migraines. So if you look at the day of the menstrual cycle, you'll see that I have a graph that I'm going to show you. There's a big spike in the frequency of headaches. Connection with the GoToWebinar server has been lost. So hopefully that's just not me. I don't know if everybody else can see the slides, but if you can see the slides. Hi.
Hi, Pelin. This is Caitlin, and I just want to apologize to everyone for the difficulties we're experiencing. I just wanted to quickly troubleshoot. Pelin, if you just move your mouse around and see if you can move back and forth on the slide.
No, it's stuck. I've tried a few times.
All right. Well, then I'll go ahead and toggle those slides for you.
Okay. So we're just going to move. We have 2 slides. There we go. This is showing the day of the menstrual cycle. Can I use my mouse here? Yes, just point. Okay. So the day of the menstrual cycle, you'll see that there's a spike in frequency of the headaches. And this is the dotted line here is estrogen level. So as the estrogen levels drop post-ovulatory, you see the spike in headache. And then hopefully everybody's seeing my mouse here. And then as the post-ovulatory estrogen level drops here, then you see a spike here in the menstrual headache as well. And then the next slide. So the relative risk of migraine, and you just kind of have to keep clicking through these, and I'll just keep talking. So just don't wait for me to, yeah, just keep on clicking. So the relative risk of migraines is showing it things a different way. 5 days and 2 days before menses. As you can see, this is menses, and these are the days leading up to it and the days afterwards. There's a 2 to 3 chance increased risk of migraine. And in the next slide, shows you the chance of severe pain. Again, we're talking 2 to 3 times more likely to have severe pain during this time. And the next slide will show you chance of associated symptoms like vomiting, where you're looking at 2 to 4 times chance. So these headaches tend to be more severe. And you can move forward. I'll catch up with you. And then, so the response to treatment of these migraines are also worse. So this looks at sumatriptan response, and if you there we go, there is a 154% improvement over placebo when you're outside of the menstrual window as compared to during the menstrual window. And if you click the next 2 slides, this is not specific to sumatriptan, this is also for bromotriptan, also the next slide, as you can see, with rizatriptan as well. Okay. So this next slide is really interesting. This shows how important it is for even giving the same pill, the formulation can make such a difference for the patient. So this is a study of 111 patients that recorded their daily headache on a 0 to 10 severity scale, as well as some other questionnaires. And so in the purple lines, what you're seeing is the first 2 cycles here is the 21/7 classic regimen. And as you can see, there's greater headache severity in these purple areas here at days 25 through 28 of the 7-day placebo. Okay. However, if these patients switch over to the same pill to a continuous regimen, and especially true for women with the higher headache scores, they do so much better, and their frequency of headaches drops. And this happens even within the first 28 days of going with a continuous regimen. Okay, next slide. And we'll just do these one at a time here. So migraine aura, can you go back? We'll just click one at a time, and I'll tell you when to click. So migraine aura is more common in high estrogen environments, and it's rare with menses. So the aura here is the little sunburst, and this is your estrogen level in your menstrual cycle. So we're just going to talk through some of the physiology and how it affects the migraines and some clinical applications. So can you click again, please? So the menstrual-related migraine is associated with the late luteal phase decline in estrogen, and that's delineated by the X there. So go ahead and click again. So the clinical implication here is that progestin-only pills are not likely to help our patients with menstrual-related migraine or migraine with aura. And why? Because these progestin-only pills control ovulation in only about 50% of cycles. I mean, they still maintain contraceptive efficacy by other means, like thickening of mucus, thinning of the endometrium. And we know also progesterone itself is a GABA agonist and has inhibitory effects on seizure and possibly aura. So it may help migraine with aura only, but not in those with hormonally mediated cycles. So next slide. Just one click. Can you move to the next slide? So if you look at just one click, if you could, that's okay. So these we're going to just do one click at a time. So if you could just hold off on any further clicks, okay? If you could go back for me. So 35 microgram ethinyl estradiol, OC, is going to match that peak estrogen exposure that you see here. So if you could click that, you're going to see the estrogen in a typical OC. So if you could go ahead and click one. Oh, there's a delay for you too. It's been one of those days. I've had technical difficulties all day, so I think I cursed everybody. So I'm sorry. You guys can just blame it on me. I knew something bad was going to happen today. So this is the typical OC, these blue bars. And as you can see, since it's peak, the peak levels of estrogen are higher, it can increase these auras which thrive in high estrogen environments. And so this can potentially increase stroke risk as well, because we know that auras are associated, increasing auras are associated with increased stroke risk. Can you go ahead and click again, please? Now, when that level drops here, that's a big drop, that 35 microgram drop after the placebo. Can you go ahead and click? That is going to increase your menstrual-related migraine because that's a huge drop of estrogen. And so the clinical implication here is that you want to use the combined hormonal contraceptives containing 20 micrograms of ethinyl estradiol or less in women who have migraine with aura, and you really want to use this continuously beyond the 3 weeks to minimize symptoms and stroke risk. And Dr. Calhoun is really going to go into details of this with you. Next slide. So with this, and then one more click, please. So again, so we're talking about this big drop here. One more click. Of course, I had to have something with the tons of clicks on it, didn't I? So in order to minimize these menstrual-related migraines, you want to drop this ethinyl estradiol to less than 10 micrograms to minimize triggering a migraine. Okay. Next slide. We're going to talk about that a little bit more. So this is the architecture, you say, of Merced. So Merced comes in many generics, but years ago when it was the first one on the market, the reps did promote it saying that this is going to be good for your patients with headache. Why? Because it was a lower dose. That was a good concept. And the blue is the estrogen. And then they added back 10 micrograms of ethinyl estradiol here, and that was a good concept too. But the problem is, if you can click here, there's this big drop of more than 20 micrograms. So again, you don't want to have any more than 10 micrograms of a drop. So once that headache gets going, it's going. So in an ideal situation, you would actually have these placebos flipped around where these estrogen-containing pills would be right here, and then you would go on to 2 days of placebo. And if you could click again, and Dr. Calhoun did do a study where she just added back the estrogen here, and she knocked out the migraines for her patients. So let's move to the next slide, please. And you can just go ahead and click through all of it just to get the entire slide, so I don't torture everybody. So this is the natural menstrual cycle here, okay? And normally you have about a 20 microgram equivalent drop. So these are the higher dose pills that we pretty much rarely use, but we don't use these 100 microgram ones, but the 51 we rarely use. But as you can see, everything here in the 30s is still going to have this huge drop during the placebo where you don't see the blue. It's going to be more than 10 micrograms. So all of these are going to make the migraines worse, like we talked about. So as you get to the 20 microgram, you're getting to the right concept here, but again, you're going to have this more than 10 microgram drop. This is the Merced that we just talked about. So this is low estrogen, 10 micrograms. That's a good concept, but the problem here is that it's an expensive brand name. This here is an extended cycle. This is seasonal, where you have 30 micrograms for the 3 packs and then placebo. But again, you're going to get this big drop, 30 microgram drop. Now, granted, you'll probably have only 40. You'll have only 4 migraines per year, maybe, instead of the 12 or 13. However, you want to try to avoid these drops, right? And this here is seasonique. So again, it's a good concept. They're adding back 10 micrograms here, but there's still a 20 microgram drop. So what's most likely to help would be low seasonique here, because it's a 20 microgram with added 10 micrograms during the placebo. So the net difference that you're dropping here is only 10 microgram. Or you can do a continuous formulation. You can go ahead and move to the next one. So this summarizes the concept that we just reviewed, but at least gives practical brand names. So with continuous formulations, there's Librel that was originally promoted, but now it's not available, but various generics are. Anything with the asterisk has been recently discontinued as a brand. But in all honesty, as a clinical pearl, just pick whatever pill that the patient prefers, a low-dose monophasic pill, and use that continuously. And you can do that with the ring as well, and Dr. Calhoun is going to present her research on that. We talked about the low seasonique, so that's the 20 microgram with the 10 microgram during the placebo. You could do the low estrogen, which is the 10 microgram. However, these do not have generics, so that's going to be a cost issue for the patient. And Natasia is a quadriphasic, but this does a good job because it limits the drop in estrogen. However, again, it's a brand name, so you can, most typically, I just stick to a generic version of whatever the patient likes, and I use it continuously. All right, next slide, please. And then what if the patient doesn't want to take something continuously or is really set on their pill? How can you help them? Well, you can add back estrogen, but the doses are going to be different depending on the dose of the pill. So if it's a 30 microgram pill, you need the equivalent of 0.9 BID of the equine estrogen. If you're using a pill that's 20 microgram, then that should be about 0.9 QD, or you can use a transdermal 0.1 daily patch. And if it's a 15 microgram vaginal ring, then you can just get away with a 0.075 milligram patch as well. All right, next slide, please. And one other clinical pearl. Oh, sorry, could you go back one? So one clinical pearl, since migraines tend to be triggered most early in the morning, keep in mind that you want to avoid those estrogen troughs early in the morning that can trigger a headache, so bedtime dosing can help prevent that. Okay. All right, next slide. So what do the guidelines say? So this ACOG 2010 practice bulletin is a little older now since we have newer guidelines, but it does say that the use of extended cycle or continuous hormonal contraception may afford relief of migraine headaches for some women. However, they caution. They say, although cerebrovascular events occur rarely among women with migraines who use TOCs, the impact of a stroke is so devastating that clinicians should consider progesterone only intrauterine or barrier contraceptives for women who experience migraine with focal neurological signs, those who smoke, or who are 35 years or older. So in the next slide, if we can move to that, is the updated CDC medical eligibility criteria. And that one was just released several weeks ago. So this is nice because it helps make things a little easier and it helps remove some of the age barriers for us. So for headaches, oops, can we just stay on this slide? So for headaches, if they're non-migrainous, then you have no issue. If they're migraine without aura, you have no issue. It's still a category 2. These asterisks here state that you make sure that you do correctly diagnose and provide the references for diagnosis that we just reviewed together. Now with aura, keep in mind that the guidelines still recommend caution, saying that overall for the risks may be outweighing the benefits. And Dr. Calhoun's going to really go into this in detail, where, which products are better, which products are safer. Many of us do use these products to help these women in clinical practice, but just know that the guidelines are written conservatively so that we think before we prescribe, and that you want to make sure that you document, and you want to make sure that you've had this discussion with the patient. So if I'm using something that's technically against mainstream guidelines, so our guidelines are just there to guide you, right, not to necessarily dictate what to do, but I want to make sure that I've told the patient there might be an increased risk of stroke, that the guidelines still are conservative, and I also want to document that the patient is doing wonderfully well with this regimen that I'm putting her on, and I want to document that she went from taking 10 abortive pills per month now to having just a few migraines per year. So that's really important for your care of these patients. And Dr. Calhoun was on the panel that the CDC guideline interviewed when making these recommendations, so she can talk to you about her experience there. The one other asterisk here, the one other discussion point, they say, keep in mind that this is for women who don't have other risk factors for stroke, such as hypertension, smoking. And I think I'm done torturing you guys with my technical difficulties, and I'm wishing Dr. Calhoun some better luck as she talks to you more about stroke risk and the controversies.
Okay, well, thank you so much, Helen. Yeah, and you're mentioning that meeting with the CDC. I'll just say very briefly there, they did a straw vote before I left. And the straw vote was to change the recommendation with aura to a 1. And I stopped them with that, said, okay, I would say doing that if you separate 50 microgram pills and all others, or go 50, 30, 35, 20 and below. And they were unwilling to separate them. And we're going to get into that in a minute talking about tigers. Okay? So revisiting the controversy. The controversy has been going on for over half a century. The article that was published in the Journal of the American Medical Association in 1975 just looked at oral contraceptives in stroke in young women and look at that relative risk. 4.5 times increased risk if they were on an oral contraceptive. Authors of that study said that a correlation of estrogen doses to stroke could not be made, since 23 of the 25 women with thrombotic stroke on the metronol-containing formulation took the 100 microgram dose, all 20 on the estradiol formulation took the 50 microgram dose. So these are all high-dose pills. Pills back then, they actually had a 150 for a while, 100, 80, 50. 50 was the lowest dose pill they had. Now, they did, though, look at women who also had migraine. And when you put that in as well, that did not increase the risk. It was a 4.5 times increased risk with oral contraceptive and stayed 4.5, no significant difference there with migraine. Now, we've gone beyond this. My best analogy of this is that there was a time in the Earth's history when cats were saber-toothed tigers and cats were dangerous. Today, most cats are little domestic things we sling over our shoulders. The problem is that we are not differentiating. Any study today on the danger of cats would be expected to differentiate tigers from house cats. We still have some tigers. We do in the hormone contraceptive world too. they account for less than 1% of oral contraceptive sales in this country, but they're still out there. Now, let's look with that in mind at some of the studies. Here's a nested case control study done in the UK. Hannaford did this, and if you look at the dates when they were looking at the data, it overlaps the time of that JAMA article. This goes from the late 60s, with the most recent one being a quarter of a century ago, 1990. So most of these early ones would be 50 plus microgram pills. The newer ones, probably 30, 35 is the lowest dose pills that they would be including in those. But the conclusions were that high-dose oral contraceptives equal to or greater than 50 had a 6-fold increased risk of stroke, but the 30 to 35 microgram formulations had no increased risk. Similar data were reported in a World Health Organization study where the risk of ischemic stroke with greater than or equal to 50 microgram pills was 5.3, but the risk with all pills below that did not reach statistical significance. It was higher. I would say 30, 35, 30, 40 pills should be somewhere between 1.5 and 2 usually. Sometimes they're statistically significant, sometimes they're not. Now, if we look at a study done in the U.S. about the same time, in that World Health Organization there were no U.S. sites. In the U.S., Petitti looked at 3.6 million women years of use, and there were 408 strokes in the 3.6 million women years. So the first conclusion is stroke is rare in this population. And I inserted the term low dose here. In her article, she just said oral contraceptives did not increase risk of stroke. Well, 99.2% of them being used in this country then in her study were low dose pills. Now, if we look at that, several things did increase risk. Smoking, hypertension, diabetes, that current use of an oral contraceptive did not
Hello?
I am. We can hear you now.
Oh, okay. Were you not hearing me before? Hello?
Hi, Anne. This is Caitlin. Yes, we were just having some trouble hearing you, but we can hear you great now.
Okay. Do I need to go back or what? Where are we?
I think one slide back would be great.
Oh, okay. The problem I'm having, I was just saying, I can't move the slides now all of a sudden. It was working fine until I this slide and it is stuck.
All right, I will take control over the slides. Just let me know when I need to click.
Okay, let's fast forward. Click one here. Okay. With the ACOG concerns, I'm going to look at them one at a time. The first was the concern that all women with migraine are at increased risk of stroke if they take oral contraceptives. Click. And this is based on a World Health Organization study that, again, had no U.S. sites. Click. And they did find several things that increased risk. Current oral contraceptive use, click, had a 1.6 relative risk, hypertension 2.7, diabetes 2.8, family history of stroke 2.8. Now, they also did a subset analysis, click, looking at folks in this group who also had migraine. And if you add what was felt to always be another risk factor for stroke, which is migraine, to these risk factors, you would expect them to go up. And click, when they looked at hypertension, it did. It went from 2.7 to, click, 3.3. Diabetes, click, went from 2.8 to 5.2. Stroke, click, went from 2.8 to 3.4. But when they looked at migraine, it went from, click, 1.6 to 1.6. So one of these, either migraine or use of the combined hormonal contraceptive, was not an independent risk factor. Click. Now, some other things were, if you look at this population, they were averaging age right over 35, and the majority of them were smokers with the cases. And click. Furthermore, if they had a stroke, the majority of the stroke cases were using high-dose pills. Click. Now, the authors of that study had several conclusions. Click. Their adjusted risk of ischemic stroke was significantly associated with migraine of greater than 12 years duration. Click. It was also associated with migraine with aura. Click. And particularly migraine with frequent aura, frequent defined as over 12 times a year. Click. But the very authors of this study, they said in no case did correction for oral contraceptive use alter these odds ratios. So it was not the birth control pill that they were adding in. It was frequent aura and migraine with aura that appeared to be the risk. Click. Now let's jump over, click, to the last of these. We're going to look at this Danish population-based case control study, which found a threefold increased risk of ischemic stroke among migraineurs using birth control pills. And then we'll come back to the other one. Click. Here is that study. Now, click. They did separate out the different oral contraceptives. Progestin-only pills, that looks like that shouldn't be significant. Click, and it wasn't. 20 microgram pills, my eyes tell me that it's even lower with stroke cases. Click, and it was not statistically significant. Now, this next one, my eyes are looking at this saying 24% versus 23.7%. That ought to be NS also, right? Click, no. That one was statistically significant after they adjusted for other factors. I've just recently done a couple of articles looking at some of these studies where they're adjusting for things like years of school. There's some very strange things in some of these cases that they're adjusting for. But 50 microgram pills, click, we have known for a half a century that has about a 4.5 times increased risk. Now, where is this 3 times increased risk? Click, right up here at the top. Adjusted odds ratio, if they have migraine, was 3.2. Click. The fallacy of this study was right next to it there. In a population in Denmark where the known frequency of migraine in reproductive age women is 16 to 19%, only 6.4% of controls said that they had migraine. Probably a lot of tension headaches and sinus headaches there. The stroke cases had the expected number for the population. Now, I will say a study done in France at the same time did do a better job diagnosing it, and the population norms were found in both stroke cases and controls. they have no increased risk. But I think this is a little bit of a fallacy with the 4,000 controls having so far fewer than the expected number of strokes. Of migraines, rather. Click. Now, let's go to this more troubling one here. Oops, and that was supposed to be lighting up the middle one. The pooled analysis of 2 large U.S. case control studies found a 2-fold increased risk of ischemic stroke among migraineurs using oral contraceptives. Click. This is a study I've been presenting a long time, and when I would present it, I would say, well, they analyze this a lot of different ways. Current users versus never users, past users versus never, not current versus current, and in none of these was there any statistical significance except that if you used oral contraceptives in the past, you've cut your risk of stroke in half. Well, but no increased risk with any of these. Now, the population's quite different. Click. If you look at this group in the U.S., the risk of stroke was still very low, but only 11 of the 1,000+ cases and controls were using high-dose pills, and 17% of cases and controls were smokers on oral contraceptives, not well over a third of them as in the other study. Click. But where is this doubling of risk? If you look up and down the pooled odds ratios, click, you'll see it only down there at the bottom where it says history of migraine. But I looked over to the left and click, this is based on only 4 cases. And when I looked at it a little bit more closely, I thought 4 out of 51 and 11 out of 119, that sounds pretty similar. And when I did the math on it, it was 7.8% of cases, 7.7% of controls, but they have an adjusted odds ratio of 2. So somehow they've adjusted equal numbers to say that it increased the risk if they had migraine. But one extremely important adjustment was not done because, click, if you look at the slide that I actually showed you just before this, a very important factor is that of those 11 high-dose pill users out of 1,000+, they accounted for 4 strokes. That should have been adjusted for. Tigers versus cats. We need to adjust for when we're dealing with tigers. It's a different creature. Click. Now, going back to what Helen talked about a little while ago, remembering that migraine aura is more common in high estrogen environment, but the menstrual migraine is associated with that drop in estrogen just before with the onset of bleeding. Click. I proposed a study for some folks of mine who had intractable menstrual migraine. They were missing work every month with it, but also had aura. Click. And what I suggested that we do with these was use an extended ring contraceptive that contains only 15 micrograms of phenylestradiol, but don't give them the week off. Just click, have them do that continuously and wipe out those high levels of estrogen, which theoretically should decrease aura frequency. Click. And if they wanted to cycle off maybe 4 times a year, some did, some didn't, I would add back a cushion of estrogen that would limit that drop to less than 10 micrograms and prevent their menstrual migraine. Click. And in that study, what we found was we cut their frequency of aura from 3.2 auras per month down to 0.2. No one had an increase in aura frequency, and we eliminated menstrual migraine in 91.3% of them. Click. Now, let's look at some more recent studies, because I think after discussing this, my bet is that every one of you can figure out what the results of these studies are going to be, because you kind of know it going in. Click. The first one was a study out of Denmark, out of Scandinavia, 15-year prospective population-based study looking at the risk of MI and stroke in healthy hormonal contraceptive users. Now, the overall risk was low for both of them, but if they look at 20 microgram pills, there was no significant increased risk of stroke or MI. If you look at the 30 to 40 microgram pills, 1.4 to 2.2. It was statistically significant this time. That's about the range you should expect with the 30 to 40 micrograms. Progestin dose had no influence on these endpoints. Click. But the better study, I think, is this next one. And I think this is the way studies should be done going forward, where you don't just look at, quote, cats. You look at tigers, bobcats, lynx, Abyssinians, Siamese, whatever. What they did was they picked 3 specific hormonal contraceptive formulations and compared them to the 20 microgram pills, which are known to have no increased risk. Nobody has shown a study showing an increased risk of stroke with 20 microgram pills. They compared oral drospirenone, the 30 microgram, that would be like Yasmin or its generics. Transdermal patch, that would be Ortho-Evra or its generics. The vaginal ring, that's NuvaRing, there's not a generic of that one yet. And compared them to those 20 microgram pills. Now, what would you expect? Well, you would expect if you go to a 30 microgram, the risk would be higher, but a 20 microgram patch should be the same. That the vaginal ring should be maybe even a little bit less, but if the 20 does not increase the risk at all, well, I guess the last 2 should have no difference from that. And that's what they found. Compared to the 20 microgram pills, there was an increased risk for stroke and MI only with the 30 microgram ones, and it was 2.01, again in that sort of range you'd expect. The highest risk was in the older cohort, ages 35 to 55, and no significant risk was seen with the other preparations. Click. Now, fortunately, last year there was an excellent Cochrane review published on this topic. They looked at all of the studies and found that combined hormonal contraceptive users are not at increased risk of ischemic stroke. The odds ratio was 1, or MI, odds ratio 0.9. The risk was only increased in women using high-dose pills, which account for less than 1% of prescriptions in this country. Needs to be fewer, they need to be gone. Risk of hemorrhagic stroke was not affected by use of combined hormonal contraceptive, and the type of progestin had no impact. Click. So in summary, argument against using oral contraceptives in migraine with aura is based on concerns that all women are at increased risk of stroke with oral contraceptives. Click. And that's false. High-dose pills increase risk, not the others. Migraine with aura confers an independent increased risk of stroke. That's true. Click. And the risk increases with the frequency of aura. And combining these factors might produce additive risk. Click. Evidence suggests otherwise. Click. Now, we have a very quick little case example if we still have time to do it. This is Patty, a 42-year-old graphic artist. She has migraines with extreme menstrual migraine and PMS. She's on a 35 microgram orphan pill and uses ibuprofen 600 to 800 milligrams 18 to 24 days a month for her headaches. And when that doesn't work, she goes to hydrocodone. The severe menstrual migraines are the ones where she misses at least a day of work every month. If you look at her sleep, she gets in bed at 11, gets up at 5:30. That's 6.5 hours in bed is interrupted twice to get up to go to the bathroom, which is not just the 2 minutes you're up. It's the hour and a half before that you have extreme sleep fragmentation. She wakes up exhausted, naps 8 times a month. I'm going through this in detail because this is a topic for another day, but non-restorative sleep is the generator of chronic migraine. All you need for chronic migraine is number 1 to have migraine and number 2 to wake up tired every morning. She has the PMS, and we'll just go on here. Click. Now, what I suggested we do with her is we've got to lower this drop. Click. This is the drop here that's giving her the menstrual migraine. Click. And she's on a pill this high. And click. Her drop is bigger than the natural 20 microgram, roughly 20 microgram drop you get with the normal menstrual cycle. So what I suggested we do with her, click, is to change this to a 20 microgram pill that goes extra days. And that would still not help, though, because that's the same drop as with her natural cycle. Click. But then I would add back half of that dose on those last 4 days, days 25 through 28. Click that. That would limit her drop to 10. Click. So in doing that, I remember this patient, and I said, well, usually we can do this with 0.625 to 0.9 if we're using an oral. Often I'll use patches here. That I like the patch better. With the patch, probably use a 0.075 to even a 0.1 in some cases. But she wanted to go with the lower one first, so she went with a 0.625, and it cut the menstrual migraine from 3 days to 2. It would respond very quickly, but it would come back the next day. She was down to 16 pain-free days. Her sleep was better, but only up to 7.5, and still taking naps. Click. So I then increased the Premarin to 0.9, which totally eliminated the menstrual migraine. Her sleep was much better. We've gotten her down to only 3 little twinges in a month, all treated quickly with a fast triptan, and the citalopram was taking care of her PMS. But click. That pretty much takes care of that one, and I think at this point, let's take some questions.
Great. Thank you both, Drs. Batur and Calhoun, for that excellent presentation. I can now read questions that have been entered into the question and chat box. So just to address a couple of the early questions I got, we will be posting a copy of the slides as well as the recording of today's webinar on ARHP's website under our continuing education section. So definitely make sure to keep checking that out at arhp.org. And let's see if we've got any questions on content. So far, it looks like most of the questions were regarding concerns with the audio. So if folks want to start entering questions in, I can read those. All right. So Perry asks, for your patient, Patty, why not use Amicia low? Am I saying that correctly?
Can you spell the name of the one she's saying to use?
Amethia.
Amicia low. I think that's a generic for low seasonique. You could do that, but I think at the time I just went on with what she was taking, and this was an actual patient. I've got, well, at one point I was doing a talk at International Headache Congress, and I reported on over 35 different ways we had prevented this headache. Menstrual migraine is the easiest migraine to get rid of. We know when it's coming. We know what's causing it. We have sample closets full of stuff to fix that with. Anything that limits that drop will do it. But it may have been when this came out that was still a brand name only. I have some people who don't want to go extended cycle. I have others who are happy never to have periods again. But everybody's a little bit idiosyncratic with those things. But yes, a generic of low seasonique would do it too.
Great, thank you. Our last question is, if a patient is on microgestin 1/20 and gets menstrual headache 3 days prior to placebo, what do you recommend?
If she's getting the headache before the placebo, it's telling you it's not inhibiting ovulation. Usually the peak day of migraine with their traditional 21/7 pills is Tuesday of the placebo week, given the traditional Sunday start. It takes about 48 hours after the drop in estrogen before you're triggering that estradiol receptor and triggering the menstrual migraine. So if she's getting them on active pills, that's not inhibiting ovulation.
Perfect, thank you.
Yeah, and I do try to set the expectation with patients that when we keep dropping the doses of the estrogen, it's like crossing over to the progesterone-only pill land. Yes, you're suppressing ovulation a little bit better, but you're still going to have some breakthrough ovulation with the lower dose pills. When you go continuous, you do get better suppression of ovulation. So, and the longer you do it, probably the better. But if patients know that every once in a while they might have breakthrough symptoms, and that does not mean that it's failing. But they're still, preventing most of the ovulation cycles. I think that's really helpful for the patient to be aware, because most people don't realize that you can still get breakthrough ovulation even on a low-dose combined oral contraceptive.
Yes, Dr. Batur is making an excellent point there. When we went first to 20 microgram pills, we were seeing a fair amount of that. Now, ovulation suppression is one of 4 mechanisms by which a birth control pill prevents pregnancy, and they're all progestin dominant. The only one that estrogen even helps with is helping with inhibition of ovulation. It was included mainly to help bleeding profiles. But when we go to the 20s, they started dropping the number of placebo days. We have a couple of major ones that are only 4 placebo days. When they went to the 10 microgram, that little low, they went to only 2 placebo days. But no placebo days also works beautifully. That was actually John Rocker's original idea when he created the birth control pill, but he just thought women wouldn't like not having a period. And I'm wondering how many of us he polled on that one.
Great point. Thank you so much. So unfortunately, that's all the time we have for questions today, but folks should feel free to send additional questions to education@arhp.org. And Dr. Calhoun, would you like to review the key points for participants before we conclude?
Slide here. Just overall key points. We definitely prefer low-dose combined hormonal contraceptives. I think 50 microgram pills need to go the way of the dinosaur and the saber-toothed tiger. To prevent menstrual migraines, either eliminate the drop in estrogen completely with the continuous formulations or limit the drop to equal to or less than 10 micrograms. Don't prescribe these products to smokers over the age of 35. And if the patient has migraine with aura, certainly discuss risks and benefits of therapy. Thank you so much.
Thank you, Drs. Batur and Calhoun. Before we end today's webinar, I'd like to share a few important reminders. As a reminder, you will receive an email from Caitlin Borsowitz in about an hour containing a link to the PostTest Survey. Your CME or Nursing CE certificate will be generated at the end of that survey. Be sure to print the certificate before closing the internet browser. If you have questions, please do email us at education@arhp.org. And keep visiting arhp.org to find copies of the slides and recording of today's webinar. Thank you again for joining us today. We hope you will take part in other live and on-demand sessions hosted by ARHP.